Dr. Naoto Ueno is director of the University of Hawai Cancer Center and professor of medicine, an internationally recognized breast medical oncologist and researcher. He joined the University of Hawaii in 2022 after more than 2 decades at MD Anderson Cancer Center, where he led the world's largest inflammatory breast cancer program. At the University of Hawaii, he leads the only NCI-designated cancer center in the Pacific, driving research, clinical care, and education with a focus on reducing cancer health disparities. An NCI designation is the gold standard for cancer programs. It recognizes the nation's top centers for their innovative research and advanced treatments. His research explores tumor microenvironment, rare and aggressive breast cancers, and novel antibody-drug conjugates. A dedicated educator and mentor, Dr. Ueno is also a TEDx speaker, author of 2 patient-centered books, and recipient of multiple national teaching and membership awards. A 2-time cancer survivor, he brings a unique physician, scientist, and patient perspective to his mission of equitable, compassionate cancer care. So Dr. Ueno, it's so nice that you're doing this, and I appreciate your time. It's Breast Cancer Awareness Month, October, and I know that what you're going to offer cancer patients and breast cancer survivors is of the utmost importance. So the first thing I want to ask you is, could you share what inspired you to dedicate your career to breast cancer research and patient care?
Well, I think it started from meeting like Dr. Hotobaji and many other well-established breast medical oncologists when I was training at MD Anderson, which is almost 3 decades or 4 decades ago. And I seen physicians engage with not just clinical practice, but they were engaged with clinical trials, sometimes engaged with basic research. So really this simple trying to translate the knowledge into clinic inspired me to go into becoming a physician scientist. And I wasn't particularly exposed to breast cancer prior to this, but really the people who I met triggered me to go into this field.
Thank you. You mentioned that you gave a TED talk, and could you tell our audience what the main point you were communicating concerning breast cancer in your TED talk?
Well, the TED Talk is about patient empowerment. It applies not only to breast, but other cancer. And you have to really take control of your journey, which is really having the right knowledge. And if you're like we talk is like you're on the map, and then you need to know where you're standing in the location you are in the journey of the cancer, but you also need to know which direction it is. A lot of people think that physicians or their healthcare provider is a determining factor, but that's not true. And we're supposed to be an equal partner. Patient and the healthcare provider is an equal partner. And that's probably the main topic.
Well, I've known you for a number of years, and we worked together on many projects and inflammatory breast cancer while you were at MD Anderson. So I have witnessed your compassionate patient care, as well as your mentorship of medical students, graduate students, and clinical trainees at MD Anderson. I remember my friend Sarah, who had been misdiagnosed at another cancer institute,
Mhm.
and she came to MD Anderson. You were her main provider and her care doctor. And you were so understanding to both she and her mother. You were always available, and you made sure that she received the very best care. So your compassion, it felt, is so genuine and heartfelt. Does that come naturally to you, or is it something you've learned along the way as you're taking care of patients?
I would say it's a process. I would have to say that you see people struggling through their process, and patient as well as my mentors or my colleagues really impacts how you how you provide the care. Medicine is about team approach, and the funny part is that this team approach we talk about a lot, but we don't teach in medical school or even during residency what is team, and team is really sometimes driven by knowledge. But I think MD Anderson, particularly, it's not just knowledge, but your interaction with your colleagues and your patient is something that's been emphasized for many years. So I think it's the process that brought me to where I am.
Well, you are exceptional on so many different levels. I mean, I've been involved in patient education for a number of years, and we started CMedEd and you've been such a major contributor to our website with the information on breast cancer, and I thank you so much for that.
You're welcome. Yeah.
Um, we believe that the more a patient knows, the better the outcome's going to be. Knowledge is power. It's power to ask questions, to, come to a decision about your treatment, and have your future. And you just have a greater understanding. So a relationship with your oncologist is so very important that you have a map of what the treatment's going to look like and the side effects of it, and what do's and don'ts you can do and how you can participate in life and going forward, if you can go on vacations with your children and grandchildren. So it's so important. You're such a knowledgeable scientist and researcher. I wanted you to talk about some exciting developments and what you're doing for breast cancer right now.
Mhm.
And can you explain to us, the benefits of an antibody drug conjugate and how it works, Dr. Ueno?
Yeah, so antibody drug conjugate, the basic is it is chemotherapy, but I would say it's a targeted chemotherapy. So the way it works is you have the chemotherapy, and then you have what they call the antibody, which is like a biological agent that binds the cancer specifically. So there's two components to it. And there's something that chemically that links together. So that's why it's called antibody drug conjugate. So ADC, the abbreviation antibody drug conjugate, ADC, allows to deliver very toxic items to the cancer more specifically. And that's why it's very effective at this moment. We have two drugs. Well, technically, we have three drugs, but the recent two out of three is extremely effective.
And so have these been approved by the FDA, and are they being used with patients right now?
Yes. So they've been approved for probably 5, 7 years. I could be wrong, but it's around that time. But the interesting part is that they started with an advanced disease, very advanced disease. But both drug, which is a the product name is Enhertu or Trodelvy, though both of them are kind of moving to the front, meaning that the first line metastatic disease and also it's going into early disease. The thing that I'm talking about is not FDA approved as an indication, but what I'm trying to say is it's really well established in terms of efficacy and treatment, so they want to make sure that they could deliver this drug in an early setting as much as possible.
What, there's so many advances that have been made for treatment other than chemotherapy. The next one I think that we talked about was immunotherapy. And,
Mhm.
this has transformed treatment in several areas. Can you explain to us its current role in breast cancer and where you see it headed in the future, please?
Yeah, so the immunotherapy was first approved for triple negative uh, breast cancer. Triple
Mhm.
negative meaning the estrogen receptor, progesterone receptor, and HER2. Three target is basically not noted. And so in triple negative breast cancer metastatic disease, combining with chemotherapy has been effective. From there, they move it to early disease, so newly diagnosed breast cancer without metastatic disease. And in that setting, when they give it, once again, the chemotherapy effectiveness goes up and they live better. So that's the area that's currently FDA is approved. But now the direction is this is also not FDA approved, but they're gonna try, there has been trying to work with this immunotherapy combined with ADC, the ADC that we just talked about, and that combination is actually showing some promising outcome. And I believe that those are going to be eventually FDA approved. And the other is whether you could give immunotherapy in like hormone receptor, estrogen receptor positive disease. That may be another area that we may be seeing in the fu near future.
That is so exciting to hear. I mean, the antibody conjugate and the immunotherapy. So women and men that are diagnosed with breast cancer are often, so often, we're all concerned with the side effects.
Mhm.
Immunotherapy in breast cancer is the ability to harness the patient's own immune system to
Yep.
target and destroy the cancer cells. So
Mhm.
it's not systemic, meaning that it does not go through your whole system. Am I
Mhm.
correct in saying that?
That's true. I mean, as you said, Phyllis, that correct.
It
You
it
enhance.
and so the antibody ADC, how does that also target just the cancer cell, or is that systemic? Does that go through your?
Well, I mean, both of them are intended to be specific as much as cancer, but there's
Uh-huh.
some reality. There's not a single drug that's no side effect. Maybe that's the future that we have to aim, and that's where the
Uh-huh.
research is going. But there is a side effect on both sides. Immunotherapy, particularly because you're manipulating your own uh, body's immune system to fight the cancer. It's a very delicate situation you will go
Mhm.
into. Yeah.
Uh-huh. Interesting. Well, then now they're also where you're investigating tumor microinvolvement and how it influences the way that a doctor treats aggressive breast cancers, like triple negative and inflammatory. And you are one of the most renowned experts on both of these, in my opinion. So can you please explain tumor microinvolvement?
So tumor microenvironment is basically that there's a cancer and there's a surrounding of the cancer. So a lot of people think we need to treat the cancer, but the reality is this cancer and the surrounding has an interaction, and that actually amplify potentially cancer to be more aggressive. So there's lots of immune cells, there's normal cells. So what we know is if we really want to get the best outcome is to control both cancer and the surrounding environment, which is a tumor microenvironment. So one of the example is immunotherapy. Immunotherapy is not simply targeting the cancer. It's actually targeting the surrounding of the cancer. But we think there's more drugs than the currently Keytruda, the pembrolizumab, which is a FDA approved drug. And that's really the only drug for breast cancer currently approved for immunotherapy. But there are so many components and so many ways that these things interact. We think that there's going to be a different type of immunotherapy or drugs that modulate or change the tumor microenvironment is going to come. And that's probably another near future, probably drugs or something will come out. Yeah.
Well, thank you for correcting me on microtumor environment, not involvement. And that, there's it's the future of medicine is so exciting. You and so many of your colleagues have come so far in discovering new treatment methods, and it's so encouraging to all of us that have had family members or are a cancer survivor ourselves, like you. Um, so interesting. How long does it take? um, for your discoveries from the lab to make their way and to be available and offered to a patient?
Well, historically, it's very, very long. So many years ago, it was probably like 2 decades, or, some people say average about 10 years. But what I'm gonna say is that recently the discovery to FDA approved is some of the drug has gone less than 5 years. So there is an accelerated process that's happening due to the better technology, smarter people, and of course, the government approval process. So there's lots of good things that's happening. It's just not one thing I could say that it's not like, okay, well, you do something and next year something will come on. I don't think it will go to that level, but I
Mhm.
think it will continue to improve.
Thank you for that. I mean, it's hopefully, can't you put those on a fast track at the FDA? I've heard that term used before, or no?
Yeah, so currently, well, Dr. Richard Pazder is the lead person of the
Yeah.
approval process, and he does have a really good process of accelerating the process, and it has gone real fast. Under his tenure, things has improved dramatically. Now, accelerated mean that they will approve with not a complete mature data. So there are a few drugs that's been actually pulled off the market because that they didn't have sufficient outcome and and side effects. And so it's a complicated thing. So we'd like to, as a patient, get excited by shrinkage of the tumor, and generally shrinkage of the tumor is a reason to say, well, this drug is good. But what we believe as a clinical investigator is not just shrinking the tumor, but you live longer, right? So if you don't live longer, shrinking the tumor doesn't really matter because think about
Right.
it. It's the extreme end is you don't shrink the tumor, but the tumor just exists and you live, you double your life. Which drug would you take? The one that you shrink and then you don't live longer, or the one that it just stays in and then you shrink, you live longer?
Of course, longevity of life. Dr. Richard Pastor, he was at MD Anderson prior. He was a colleague of yours. He's a friend of mine. He's a friend of yours. And, he has made great milestones at the FDA in the terms of getting drugs approved to help people. He's a medical oncologist himself. So, no, we're so happy. He's just done a wonderful job there. I'm now going to switch.
By the way, Dr. Pastor was my fellowship director. He,
Well,
he's the
there
one
you
that
go.
who interviewed me, and he's the one that I don't know if he made a final decision, but I got into fellowship at MD Anderson. So
Well, I'm sure you had your own talents and attributes to get into MD Anderson. You're one of the most brilliant medical oncologists and compassionate doctors that I've ever met. And I want to switch over now to the University of Hawaii Cancer Center. It's unique because it's the only NCI designated cancer center in the Pacific. So and I know that this can be quite challenging. I want to explain a little bit about being an NCI designated hospital. I mean, you go through rigorous standards to become that. And it is the gold standard for cancer programs and is bestowed upon the nation's top cancer centers in recognition of their innovative research and leading edge treatments. So, how will you work to address the health disparities in Hawaii and the U.S. affiliated Pacific Islands? That must be very challenging.
it's a challenge. It's been a challenge for many, many years. But one of the biggest challenge we have is the geographic isolation and the vast area that we cover. So
Mhm.
Phyllis, as you just mentioned, Hawaii itself is not contiguous. So that means that you can't drive and go to the next, town. So that's one thing. So we have lots of different islands in Hawaii, but we also cover the entire Pacific from west of Hawaii. So that covers like Guam, American Samoa, Marshall Islands, and and there's about 2 million people living there. So geographic isolation, poverty, and then the other is that depending on your race, the outcome is different. So Native Hawaiian and Pacific Islander comparing to white or Far East Asian, the cancer death rate is much, much higher. So it's a perfect storm. And so we have to address depending on what resource we have and what is a high priority disease. Many of the cancers that we have a similarity to Asian countries.
Hmm.
Um, we put a lot of emphasis on education and prevention. We have one of the largest data set related to what we call multi-ethnic cohort, not just the native Hawaiian Pacific Island, but Caucasian and many different data. And this has had significant impact on the current standard in the United States, how we prevent cancer. So we have been successful not because we're able to bring the most latest proton therapy to this remote part of the world, but really more of diet, exercise, education, and by that we've been reducing the death rate in our area.
Well, if anyone can meet the challenge, I feel confident that you can and will. Um, I know you have transportation issues, language barriers, socioeconomic factors, and I read where Native Hawaiians and Pacific Islanders often experience higher rates of chronic diseases such as diabetes and heart
Yep.
disease. So
Right.
not only do you have that, you're also facing people that are diagnosed with cancer. So um,
Yeah,
we,
during the World War II, processed food was introduced, and you probably know the food product called spam. And
yes.
this is not a criticism of spam, but unfortunately, because we cannot get a fresh food to the area, so a lot of people like to eat spam and other processed food, resulted into high obesity rate and the one that Phyllis you just mentioned about chronic disease, leading
Hmm.
to diabetes, obesity, hypertension. So this actually impacts the cancer rate.
Oh my goodness, that's so interesting. Thank you for sharing that. Well, partnerships are central to your vision. Can you share how collaborations with health systems, community organizations, and global partners are strengthening cancer research and care in your region in Hawaii and the Pacific Islands?
So we have two component to it. We work with multiple different healthcare care system, and I am the president of the Hawaii Cancer Consortium. So we align the cancer service line by working together. They do compete, but at the same time, they recognize that competing doesn't help. So that's a really a good strength that we bring. It's very unique. Probably it's not possible like in Houston or Dallas because they're probably more cutthroat in terms of competing situation. So that's one. The second is that we do reach out to Asian countries and we work with like a National Cancer Institute in Japan. So we are in the process of whether we could be part of the clinical trial network in the Asian countries, given of the type of the disease we have.
That's very exciting. And you have such vision for cancer and people and helping others. As a cancer survivor yourself, how does that experience influence your leadership, your research, and your vision for the University of Hawaii Cancer Center?
Well, I want to make sure that regardless of research or non-research activity, patient comes first. It's something that we all talk about it, but it's very difficult to accomplish. So when we do planning in terms of care, planning to terms of research, sometimes we forget the patient and we also forget the community. So one of the uniqueness that we have is that we have one of the best community advisory board and we have community advisory board for a general one, but we also, because we know Native Hawaiian, Pacific Islander, and Filipino, they have their different needs. So we have a CAB of general one, but we have a Native Hawaiian, Pacific Islander, and Filipino separately. And then we have a Pacific Patient Advisory Committee. So it's these committee, it's not just committee, but I try to, give them opportunity to be engaged in research or community engaged activity. So Yes, our community outreach engagement office is one of the best in the nation due to the long history, not because of me, but historically, that's really where we shine. And so we're trying to really to become a model, even in the most challenging situation that we're in.
Dr. Wayne, I knew you when you were going through your cancer journey, and I recall that you went back to Japan to have a bone marrow transplant. Is that correct? You want to talk a little bit about that?
That is correct. So when I was diagnosed with what we call myelodysplastic syndrome, commonly known as MDS, which is a pre-leukemic condition, and I end up needing a stem cell transplant. I was given a choice of receiving multiple different type of treatment and then eventually doing transplant or doing this up front. So it's basically slow death or fast death type of thing. But I decided not to get my treatment at MD Anderson, and this is not because of MD Anderson is excellent, but you have to remember that you don't want to get treatment from your colleagues because one of the things I noticed at MD Anderson, they're excellent, but um, they have a tendency to overdo it because they want to do the best for you. But doing the best sometimes is not always a good thing. You want to always be driven by evidence and knowledge. So that's why knowledge is important, right? Because sometimes as a patient, we want everything as much as possible. But there
Mhm.
are a lot of times that you don't want everything, and sometimes you should wait. Waiting
Mhm.
is always frustrating. So finding that right pace was important, and my donor was not in Japan, so I decided to jump off United States and go over there to get the transplant.
Yes, knowledge is so powerful. I remember you and I were planning a benefit for the Inflammatory Breast Cancer Center, and while you were going through that, you would call me from Japan, and we would talk. And I mean, you kept working the whole time you were there, receiving your on many different levels. So you are just so unique and so competent in everything you do. So my final question is, looking ahead, what gives you the most hope for the future of breast cancer treatment and patient outcomes?
Well, I'm excited that I'm confused with so many new things coming up. So that's what my gives me hope, right? So in the past, probably 10, 15 years ago, yes, new things were coming, but not to the point that every 4 months or 6 months something new comes and I'm scrambling to update my knowledge. So there's definitely a tsunami of knowledge, and having digesting is difficult, but that means it's good actually. So
Hmm.
I think what I see the future is that many people is working on different things, and this tsunami could be even amplified. And so I'm hopeful that multiple knowledge will help the cancer. Like I say that we just talked about drug conjugate and immunotherapy, but there are many, many other new modalities that's been explored. So eventually, I think that subset of like people who have advanced disease or rare and aggressive disease, it will become a true curable disease, and people will say, well, breast cancer is not a big deal. So I'm hopeful that that would come in within a decade.
Oh, I mean, it's so important. I mean, just what you said. I mean, breast cancer is something you go through. It is not a life-ending event. And I
Hmm.
do hope within the next decade that that will be what we tell everyone.
Yep.
Well, mahalo, Dr. Ueno. Oh,
Yep.
you are a distinguished professor, acclaimed author, TED speaker, brilliant research, and deeply compassionate breast care oncologist. I am truly humbled and honored to call you my friend.
Yep.
May you continue to find success in all your endeavors. Your work has transformed and touched the lives of countless women and men facing breast cancer, and for that, I offer you my deepest gratitude.
Great. Mahalo
Alo-
nui, Phyllis.
Aloha, give
Yeah.
me one my regards, and I hope our paths cross very soon.
Yep. Aloha, Phyllis.
God bless.